tell you is that this is the very first ADEA webinar. So if you notice a couple of technical glitches, there's a very good reason for it. Hi everybody, it's really nice to have you here. Thank you for giving up an hour of your time this evening. As Rachel said, I'm doing this as I guess I'm coordinating the review of the ADEA guideline. And it came about because I'd been doing a Masters in nursing and I was required to do an evidence-based guideline review. So being a passionate ADEA member and diabetes educator and having a real interest in insulin injection technique and injections of GLP-1, I decided to review the evidence-based guideline for our injection technique. After I'd done that, I sent my literature review and evaluation through to National Office. I was aware that the guideline was due for review this year, and so it just seemed foolish not to share the information because I'd done quite a lot of work. And as a result of that, as Rachel said, I was asked to coordinate the review of the guideline. So here we are this evening. And what I want to do tonight is introduce you to the changes that I hope we will see in the guideline. But most importantly, I want to get your feedback on the usability of the current guideline and any additional information you'd like to see added. I have some fairly strong ideas about how the direction that I'd like to see it go. We have an excellent document that's already in place and some really important groundwork has been done, and I think the time now is to expand on that very good work that was done and yeah, to take it to the next step. So I'm going to move on to showing you some slides. I'm going to get rid of my facade and just show you my slides. So here we go. Okay, so you've all seen this slide. You hopefully saw it in the ADEA magazine that came out yesterday. So you can see that tonight we have 4 main objectives, and I'm just going to work through them gradually as we go. I'm going to start with having a look at the evidence that I've reviewed for the guideline and explain a little bit about how I've done that review. As I said, I'm very interested to hear your thoughts on the current guideline, how well it reads, what the layout, what you think of the layout and what we might want to do to improve the ease of use and the practicality of that guideline. And one of the new things that we want to do moving forward is to develop a consumer resource. So that would be a document that complements the guideline, and I guess it's like when you open up your electrical items that you've just brought home from the shops, you've got the manual and you've got the just get started guide, and the consumer resource is a little bit like the getting started guide for insulin and GLP-1 subcutaneous injections. Rachel's already said a little bit of this, but as you know, the guidelines were developed in 2011. It was developed in response to some fairly significant changes that we were seeing in research, in product development, and certainly in the way that we were educating our patients regarding subcutaneous injection technique. For those of you who aren't aware of the Tauchmann review, the Tauchmann review was a very large group of people that were pulled together in Athens who looked at an enormous amount of research and pulled together best practice guidelines that have been adapted for use around the world. And certainly our guideline has been very, very effectively informed by the Tauchmann review. But of course in the last few years we've had some changes in research, there have been new developments, and so it was just time to have another look at it and see exactly how effective our guideline is and where we might need to go next. So when I reviewed the literature for my initial review, these were the sorts of subjects that came up. You can see it's quite a big list. What it should also tell you is that there's a lot of research being done. It's been interesting today. We've had some questions regarding needle lengths and whether we should be telling people to change needle lengths when they're on pre-existing needles for subcutaneous injections. But there's a lot more to injection technique than just that. and I'm going to start to talk about additional things we might want to introduce. In the evidence, one of the things that comes out very strongly is that the use of arms as an injection site is really not widely recommended anymore, and I'm sure that most of my peers would agree, or I'd be surprised to hear if many of you were recommending it. As we know, it's difficult to do that with two hands, and it's very easy to inject intramuscularly if the arm is used. So that's certainly one of the big things I'd like to do, is to take that recommendation out of our guidelines. The current sites that we recommend for subcutaneous injection, aside from the arms, will remain. But what I'd like to see added is information about what's efficacious about individual sites. So as it stands now, our guideline does have some of this information. But what it doesn't have is the evidence, and if you're familiar with some of the newer guidelines that ADEA is bringing out, you'll start to notice that evidence statements are being made to back up recommendations that are being made in the guidelines. And that's the sort of change that I'm envisaging, that we'll have these statements about what to do to make the guidelines, to put these guidelines into use. And then for those who want further information, that evidence is going to be explained in a slightly different format to what you're used to seeing in our current guideline. A couple of other things that I'm trying to get good evidence for are certainly the frequency of reviewing injection assessments, including the examination of sites and the technique of the device use itself. The volume of the insulin depot is something that seems to have some varied evidence globally, and I'm still looking into that to see if I can find a consensus. And one thing that I found that I felt should be added was whether or not you can mix insulin in the same syringes, and because it still does happen in some healthcare environments. And ultimately, I think our guideline, we want to see that being used as the benchmark for all people who are giving subcutaneous injections in whatever healthcare environment they happen to be in. I might come back to this slide a little later on, and I'll just keep moving forward and just share my thoughts with you about what I think of our guideline. You may disagree with me, and if you do, don't hesitate to say so. Those of you who know me will know that I don't mind disagreement, as long as you're nice about it. I think the title of our guideline is really wordy, and I've been working on this guideline on and off for roughly 18 months now, and I still can't remember the whole thing. I have to look it up. You can see I've got a couple of overseas examples there. They aren't necessarily less wordy, but I do think they're easier to remember. So one of the things that I'd like to put to the membership is that we have a look at just making that name something that's a little bit easier to remember, so that if you want to search for it on Google or whatever web engine you want to use, you'll actually find that very easily. The three guidelines that I've listed here are the main ones, I think, globally that people seem to refer to. So that's the other reason why I've put those names up there for you. The other thing is that our guideline is great. It was based on all the evidence that was available at the time, but I do feel for my own use that I can't get to the information that I want very quickly. I have to read it very carefully. Now, you might say, yes, we want people to read our guideline, and I definitely agree with you. But I think what I want to be able to do is to see a guideline, as I said, where you can immediately see the information that you need, and then you can come back and see what the evidence is when you're able to. I think by having a guideline where the evidence is separated out, it just makes it more easy to digest. The other thing I consider when I make that suggestion is that there are people reading our guideline who may not be registered nurses and credentialed diabetes educators. And I guess I don't want to make our document appear to be exclusive to our group. I think, you know, we're really committed to what we do, and we want to be offering people best advice. And I think if we can do that in the clearest possible way, then that just makes sense. I'm sure you've read this several times now. I've come up with a number of different headings, and I'm going to go through these headings one by one so you can start to see a picture of how I'm hoping the guideline might move forward. Excuse me. So the first topic I would look at is the key topics for diabetes education. And this is what we used to call survival skills for those of you who've been a diabetes educator for a little while. This is the list of things that I feel are probably what we want to teach people. Now, that doesn't mean that our guideline needs to go through each and every one of them in great detail. There are other places to look for information about hypoglycemia and blood glucose monitoring, for example. But where there's relevant evidence, I want it to be stated so that it can be easily found. The other thing that I'm hoping to achieve by creating a list that looks like this is to draw to the attention of people who aren't diabetes educators that there's more to teaching insulin injections or subcutaneous injections than just teaching the use of a device. And I think this is a nice comprehensive list that will hopefully do that. If you can think of something I've left off, again, please let me know. These are the sorts of things where my peers are going to be able to help enormously. The next subject is really about documentation and the teaching side of subcutaneous injection technique. So again, a lot of this information was already in the guideline, but it was written in a different way. So what I'm wanting to do is to break it down to emphasise the importance not just of the initial education for subcutaneous injections, but also the follow-up that's required, and that it isn't just a one-off job. And that often, as diabetes educators, you and I, we all know that there are times when just reviewing a patient's injection technique makes a huge difference to their blood glucose control. In terms of evaluation of injection technique, I'm wanting to introduce a couple of extra things here. So lipodystrophy is already covered very nicely in our current guideline, but the other thing I'd like to do is to introduce about the clinical signs of problems with injection. I can remember when I first became a educator in 1998 reading some very good information about how, excuse me, how to know if there are problems with injection technique. And I'd like to see very simple things like that put into our guideline. I also want to, as you can see, establish that there's an expectation that this is not a simple task, and that it's once somebody starts injecting a medication that they actually need to be evaluated again and again and again throughout the life course of their diabetes. Then we come to other considerations. These are the things that you need to know when you're teaching somebody to inject, but you might not need to know them all at once. So that's where mixing in syringes for insulin comes in. That insulin depot, that you know, what happens when we get to those very large doses of, you know, do we stop when we get to the total amount that the pen will dial up, or is there actually an amount where we should consider dividing that dose up into smaller deposits to be injected? Concentrated insulin is starting to come onto the market. I certainly have a client using 500 unit concentrated insulin, but I'm sure many of you will know that 300 unit concentrated insulin is going to be coming into Australia, hopefully in the not too distant future. And then you can see there are various other things. Pregnancy needs a mention, and I felt that this was an appropriate place to put it. Pediatrics, I feel, will fall right through this document, but I did wonder if we should put a comment about pediatrics in the other considerations as well. Things like, you know, the correct needle lengths when getting supplies, and making sure that people actually know what they're asking for when they go to the pharmacy. Then a new section would be issues for healthcare settings. So things like needle stick injuries and not sharing devices, sharps disposal, and use of syringes and where it's appropriate. So, for example, if you have a hospital setting where a person can't deliver their own insulin, what do? Do you use a retractable needle? And if you do, is there a rule about recapping? Can you use syringes? And if you use a syringe, is there a different technique required for injection? There also needs to be a comment in here about the use of GLP-1s, because at the moment we only have those pre-filled devices for our twice-a-day GLP-1 medications. And the other thing to think about is who is actually going to be using these guidelines. In other words, who are our stakeholders? So I know that there are probably some people in the audience who are diabetes educators. Maybe some of you work out in the community and domiciliary services, in general practices. Obviously there are paediatric diabetes educators within our group, and aged care is another group that many of us will have a lot to do with. But the other part of our audience is consumers, and we mustn't forget them. As I've already said, with such a broad audience, and with the ADEA's, that important move towards being the peak body for diabetes education, I think this guideline needs to try and address questions that people outside our scope of professional practice are going to have. Now I'm going to move on to the new part of our guideline, which will be the consumer resource. And as I said before, this is a separate document, so it'll complement the evidence-based guideline, and it'll summarise what I've called action points. So it won't have the evidence statements that our guideline will. Our guideline will be a much bigger document than we're probably used to seeing now, I hope. And the consumer document will be perhaps something that you can give to a patient or use when you're teaching other healthcare professionals about injection technique. It'll be easy to read and easy to understand. And an example of a consumer resource would be your consumer medicines information. So it covers off the important points that you need to know about a drug, but it doesn't necessarily go deeply into the evidence around why you do certain things with a drug. A couple of subjects have been proposed by ADEA, and they're all very reasonable. The question is, what else do we want to put in there? Do you disagree with these subjects? And one of the ideas I've had is, do we want to come up with a format for the documentation of injection training? I've put insulin there, but it would be for GLP-1 as well, of course. So again, I'm thinking about those people who don't do this every day and who might just want something that's really easy to refer to. You know, Joe Bloggs has come in, they need to start a basal insulin, and the practice nurse perhaps doesn't do it every day. So something that would be a tick box document that can be scanned and saved into a patient's record to make sure that all of those things are covered off. And obviously I want your ideas about other things you think would be helpful. Now that's the end of the formal part of the presentation, and obviously now we want to hear from you and what your thoughts are, your questions, and we want to acknowledge our sponsors without whom this would not be possible, and you can see their names up there. So I'm going to hand the forum back to Rachel now, because Rachel hopefully has been getting some questions from you, and she's going to give me an idea of what those questions are.
Thanks, Peter. I've had a couple, so I guess they're mainly comments at the moment. So if you
that's fine.
I'll just remind everyone, if you would like to ask a question, please either type it in the chat box, or if you've got the pane on the side of your computer with the little raised hand symbol, you can raise your hand as well, and then I'll unmute you and you can ask away. So I've just got a couple of comments first. So one of the comments was you can't get any longer than 8 ml needles now. And that was just the comment. And the other comment was childcare.
It is a good comment, but we also have to be mindful that there are people out there that may not have changed, and we need to know what to do with them. So you're right. I guess when I think of that, I'm making reference to those people who haven't been reviewed by a diabetes educator or somebody else and haven't had up-to-date information.
The other comment we've had is childcare settings and out-of-school hours care, where children in their care who may have diabetes may also use this as a resource, a consumer resource.
Yep. Okay. That's a really good suggestion.
Yeah, we've also had a comment saying, great work, Peter.
Thank you.
I'll just, so Jane...
You can send me a check anytime.
Jane Lehman has a question, so I think you should be able to talk now, Jane.
Oh, hi, Peter, can you hear me?
I can, Jane. Sorry, I've got a frog in my throat.
I know, I just got you with your water thing. I can see you.
Sorry, I have to do it.
Look, Peter, well done.
Thank you.
Great to see such a thorough review, and also to ADEA, but also the chance to do a webinar at this phase is a new initiative, and I think it's a fantastic one. Just a couple of things. I've just written a few things down, so I thought I'll just quickly check with you. I guess the 12mm needle issue would come where people have stockpiled standard syringes. And
yeah.
I still see people within disability and aged care facilities where they're quite often ordering from their suppliers. So there are still people out there with the 12s. When you come to write this document, the term CDE diabetes educator versus healthcare professional is probably something that needs to be given some consideration because of what you said with the different target audiences for this. And I wondered too whether some of the photos from the Becton Dickinson competition could be, that was run at the conference, that showed a number of different issues related to lumps and bumps on people's body.
Yeah, that's a really good idea.
So I think some of those would be great, because I think the more visual, we always make our guidelines and often our handouts very text rich.
Yeah.
And quite often if there's a really good edit, we can get rid of a lot of the waffle. And no offence to you as a writer, it's not meant to be anything about
No.
But I think just
you haven't read my version yet, so that's okay.
Yeah, exactly. But I'm just saying generally, keeping them simple, keeping them tight, and especially the consumer one as well, both using some images to get across some of the ideas. And the issue of click needles, particularly for older people and the disabled, there's certainly a lot of issues around consumers accessing them, because you send information through, even when you write it to the NDSS pharmacy, it might be worth you finding out what the procedure is to do with NDSS and the way the pharmacy stocks the needles, because that's the interface for the consumer. And I've been told that they only get to order their stock once every 3 months, and they have to order. So I'm not sure if that's correct, but that would have an impact on the advice that needs to be given within a consumer document.
Yes, that's good.
And also the role of the clipping devices with travel and safety would be fantastic to include. I did wonder if you found any research around the use of disposable pens versus non-disposable pens when it comes to administering larger doses.
No, nothing stands out. Have you?
Well, it would be really interesting with this one to hear from others.
Yeah.
I've noticed that if I'm actually gone back to using more of the non-disposable devices, because their administration action is actually much stronger and smoother, especially on larger doses. Now that the needles have become thinner, even though they're bigger with the bore inside of the needle. So I suspect there's not been any research done, and some patients will also split the big dose up, giving two, so they've got 2 depots instead of 1. So again, I don't know if there's any research around on that.
There's certainly been research done around the action of the devices in the design. I'll have a look for that. That's very interesting. Thanks, Jane.
That's okay.
What else do we have? Hello.
Sorry, Peter.
I appear to be here on my own.
That's
right?
okay. So, can you hear me now?
Dead air there. I'd never allow that on commercial radio.
Okay, so next we had a question.
Yes.
Have you had your literature review formally assessed by your university when you're doing your Masters, I'm assuming?
Yes, I have. And I sent it to ADEA after the assessment.
Yes.
Is there a reason for the question?
That was just a question. So
Yeah, no,
they might write
it was
that.
formal. Yes. Yeah, and I've actually shared it with BD and Novo Nordisk as well.
Okay, another question. We have some sort of flow chart for health professionals that don't teach injection technique versus often would be beneficial. So a different one perhaps for diabetes educators and people that don't teach it very often.
Okay.
There's another question, no, just a comment perhaps. I agree the current guidelines are a bit wordy. Do you think we should include GLP mimetics in the updated guidelines? I think content index...
I'm sorry, can you go back and say that again? There was some static and I didn't catch you.
Okay, start again. I agree the current guidelines...
Sorry.
That's okay. I agree the current guidelines are a bit wordy. So there's one on your side. The question, do you think we should include GLP mimetics in the updated guidelines? And I think content index should include more topics to find it easier to search for topics, which I struggled with. Also, is pinching up as recommended with pregnancy still recommended? And despite using 4 ml needles, this is suggested in current guidelines.
Right. I'm scribbling as you tell me these things. Okay, I'm not quite sure what's meant by the question about GLP-1 because it is already in the guideline.
Yep.
And yes, it will be in the new guidelines. So perhaps it's the way I've been explaining it because I tend to say insulin too much. Excuse me, but it is a guideline for subcutaneous injection technique.
Yep. Do we know the pinching up as recommended with pregnancy is still recommended, despite if we use the 4 ml pen needles?
I'm sorry about the coughing. I'm going to have to look into that. Pregnancy is not my strength, but I've made a note of it, and I will endeavour to put some information in the new guideline. It's a good question. I would say off the top of my head probably not, because we have shorter needles, and in pregnancy my understanding is that it has more to do with site selection. Sure that the injections aren't given in the front of the abdomen.
I guess the next question I can probably answer. So will you develop a working committee for the final document? The final document will probably be reviewed by the ADEA Clinical Practice Committee. But I guess if you've got a really strong interest and you'd like to have a look at it, feel free to let us know in the comments for the survey at the end, and we'll be sure to try and send them out to you so that you can have a look at them. Next question.
Just a comment, Rachel. The time frame that we're looking at is going well into next year. So this isn't a rush job. The tentative launch is around May of next year. So if you do have an interest in commenting, you will have an opportunity to do it.
Yeah. Question. One of my clients told me that injecting insulin with 8mm needles is more comfortable compared to 4mm. What do you think about this?
What do I think? I think it's very subjective. There's quite a bit of, that's a good answer, isn't it? There is actually a lot of research out there about patient preference and patient comfort. It's difficult to know, though. You can't do a double-blind crossover study with an injection needle because people can always see it. And so when you look at the evidence, it's hard to know how much of that feedback in the research is subjective. Having said all of that, it's one of the things I'd actually like to address in the guideline. And also, as a side issue, where we don't want to use 8mm needles and longer, and what we do with people who are using them now.
Okay, comment. Thanks, Peter. We should keep our discussion to peer review evidence-based studies and not individual practice. You feel that's what's happening?
Yep.
Yep.
That is what's happening, yeah.
Okay, next question. What dose level is appropriate before splitting the doses? Just something like BD.
It's a question that I've yet to answer, and I addressed that in the presentation just now.
Yeah.
Possibly you came in late, and if you did, I apologise. I don't know at this stage. I'm looking at that question. It certainly came up in the literature review. Different countries have adopted different practices, but there doesn't appear to be a huge amount of evidence around it. I'm still ploughing through a lot of papers at the moment, and I'm hoping to answer that question a little bit better.
Okay. There's a question, could you refer to GLP-1 as non-insulin injectables?
It's a good thought, actually. I don't know what the answer is. I think it's more of a rhetorical question.
Yeah. So something to consider?
Yes.
We've got another question from Jane Lehman. So just because you've already had your name up there, Jane, is there a paediatric representation on the webinar? So is anyone here, I guess, from paediatrics? So
yeah, I was wondering that too.
Yeah, so that we can get that insight for Peter and her
And pregnancy as well, if there are any midwife diabetes educators.
So there's a comment, I meant perhaps these guidelines should just be for insulin injections given that there will be newer GLP mimetic devices and different techniques including priming.
Look, it's a fair comment, but I think at the moment we can safely say that there isn't any specific research available about GLP-1 mimetics to do with injection technique. And our practice at the moment is to offer the same advice. There are small differences to do with preparing the device, but otherwise it's pretty much the same. So it's not that the comment is incorrect, but I think that we probably want to do that for the next guideline review when there's a bit more evidence available to work from.
Okay, I think we're nearly at the end. We're getting there. Will you be addressing the issue of injecting through the clothes with the shorter needles?
Yes. It's actually, there is reference to it in our current guideline actually, but yes, I will. Excuse me. There's always been a small number of papers out there about this, but now that we're using shorter needles, our approach to the evidence has to be slightly different. So, yeah, I want to expand on that a little more.
Do you include specific needle sizes for different devices? For example, we use 5mm needles for protophane.
No, that wouldn't be appropriate because you're choosing your needle length based on other factors.
We do have some members here from paediatrics. We've got from Princess Margaret Hospital in Perth, so that's good.
Hello.
And Sue says, at PMH, we tend to use insulin pens from diagnosis. We mostly use 4mm needles, though often there is pain with Lantus, and we may move to 5 or 6mm needles.
Mm. Yeah, pain on injection with short needles is one of the clinical signs that it might not be going in deeply enough.
And another comment, I work with pregnant women with diabetes and with GDM. So been using size 4mm needles now for about a year. No anecdotal evidence that there is any better or worse control. Shorter needles definitely ease anxiety. Problems come when we reach large volumes though.
Yeah. And that is starting to come through in the evidence that a lot of the research that has been done with the 4mm needles has been done with relatively small doses. That's not all the evidence, but that's certainly some of it. So looking at larger doses and how it affects your choice of needle length is something that will be looked at in the guideline.
There's also a comment that pain with Lantus is due to the high acidic levels that doesn't occur with Levemir.
Can be, particularly if glargine is cold, but it isn't always the case, and it isn't the case for everybody. And sometimes that discomfort has more to do with the site selected than the actual medicine that's being injected. So it might be that an individual needs to try using their glargine in a different part of their body or a different part of their abdomen, and they might find that discomfort goes away.
Another question. With your literature review, are smaller pen needles still recommended whether clients are obese as per current guidelines? Also, is there any evidence re insulin leakage and needle length? The longer the needle, perhaps more suitable for larger volume.
There was a bit of static there. I think the first part of the question, I think, was have there been any big changes to the recommendations for needle length?
Yep.
And the short answer is no. So there's nothing wrong with our current guideline in its current format. The guidelines we have are perfectly useful. And as I said before, it's taking it to the next step and including extra information so that when you follow the guidelines about which is the right needle to use and you start to see problems, you can then develop a conclusion about the reason for that problem and what you might then choose to do about it. That information isn't currently in our guideline. There was a second part to that question, Rachel. I think.
There was, sorry, I'll go back. Is there any evidence regarding insulin leakage and needle length?
Insulin leakage. There is some work being done around insulin leakage, but it's actually it's very hard to assess apparently in the clinical setting. So again, I'm looking at it. It doesn't appear that insulin leakage pertains to the length of the needle, but there could be other reasons for it. So, for example, not leaving the needle in situ for long enough after the plunger has been fully depressed.
Okay. Just ensuring that you have evidence about the pain issue that we were talking about between Levemir and Lantus.
Yeah.
Make sure that's evidence-based.
I have actually read quite a bit about it. So that's where my comments came from.
Will there be a checklist developed and rolled out for diabetes educators to use to record education and review of insulin administration and injection technique? Or does everyone have to develop their own?
Yeah, that's a good question, and it's a question that I've asked as well, because I've worked in places around southeast Queensland that do have their own checklist, and the problem with developing a checklist is that sometimes the organisation needs to have a say in the development and what it's going to look like, and the medical department has to review it, etc. But at the very least, I think we can provide something that's simple and straightforward, so that if someone is looking for a starting place in developing a guideline for their own facility, or if they aren't familiar with that sort of education and they have to do it infrequently, then at least there's something to refer to that might be helpful.
How big were the study populations generally in the articles reviewed?
Oh yeah, look, I've read so many papers. Some were small, some were big. You know, there's thousands of people in some of the studies, and others which aren't particularly good only might have 10 or 20 people. So yeah, we're talking about a lot of studies. I've referenced over 50 papers at the moment, and I've got another 30 or 40 to go through. When the guideline is sent out for comment, all of that stuff will be there. So when you look at our new guideline, just as you do now, you can actually go and look for those papers and see what's there.
Another question, if we assume that healthcare professionals other than CDEs are using this information, even with the checklist, there is no way of knowing if the information given is correct. Do we need to be concerned about this?
It's a good question, actually. I think if our guideline is evidence-based, I don't see any reason why it would be a problem. That's probably a question for ADEA to fully answer. I know when you teach injection technique, you are then responsible as a CDE or a diabetes educator if there are problems. So yeah, it's a good question. Thank you for asking.
And I guess ADEA's response to those sorts of questions is always we all, you know, work within our scope of practice. And, you know, even CDEs, we can't control what they're doing. So even if they are CDEs and they're following the guideline, how do we know they're still doing it correctly? So it's just one of those things. Another question, I have a client here's a specific one for you. I have a client who needs 130 units of insulin. Is it advisable to divide and inject in what needle size?
Yeah, what needle size I can't answer without seeing them. Have a look at the ADEA guideline for some ideas. The current guideline will inform you very well in that regard. In terms of splitting the dose, yeah, this keeps coming up. It's very interesting. I think our tendency here in Australia is to wait till we get to 60 or 70 units. And I'll bet there are people listening who have a different practice. Some people will wait until the dose has gone to the maximum amount that can be dialed up on the device. Overseas, the Danish Nurses Association recommend a maximum of 40 units. So for a patient like that, you're talking about having 3 injections. So my personal opinion is I would definitely advise them to divide their dose. Whether it's given at the same time of day or whether it's given at different times of day, that's probably something to discuss with the prescriber. Watch this space because, as I said, I'm still looking at the evidence to find out if there is a concrete answer to that question.
I guess the next question is based on the comment that the guidelines recommendations won't change very much in terms of needle length. So the question is then, why are 8mm needles still available on the market?
That's a good question. There's a place for them. I think the statement in our guideline is that needles equivalent or longer than 8mm needles are not generally recommended. But it doesn't say we shouldn't use them at all. That's different for 12mm needles. They are not really recommended anymore. But when you're looking at using an 8mm needle, there are safe ways to do it. And it involves using a lifted skin fold and considering the angle of insertion of the needle. So we are going to have people out there who don't want to change, and I've met them. So we need to be able to address what is going to happen if somebody comes in with a preference for a needle that might not actually be what we consider best practice?
Oh my goodness. There's like a whole heap of questions just turned up. How often?
Okay, well, just to let you know, it's 6:30 now.
It is 7:30 our time.
We might have to cut it down to one or two good questions, Rachel.
I'm just sorting through. So I guess this is a good question, and Jane has actually written a comment back to it as well already. How often as a DE should we review insulin injection technique as per the evidence-based practice?
It's a minimum of annually. That's the minimum. But obviously if you think there are more problems I should say, with blood glucose monitoring, I'd be looking to do it more often. If you have the opportunity to do it at every visit, that wouldn't be a bad thing, but probably not practical.
And Jane has made a comment here. It's not the role of the guidelines to enable us to base our own checklist on to take account into other issues and also ensure ownership of the need to review and update. So that's within our clinical practice to, I guess, know what to do and how to do that. What is a good one, I guess, if people are looking to review documents themselves? What type of search engines have you used?
Well, I've used a few. I've been using the university database predominantly, but I also reached out to Sanofi, to BD and to Novo Nordisk, to Lilly. I asked their medical departments if they could do searches for me. So the databases that have been used are the ones that you would probably use. So things like Sinal and Medline, things that are fairly common. Looking at Cochrane reviews, which really aren't very helpful, to be honest. I hope that answers the question fully. I've certainly not, I'm not stupid enough to think that I've got all the answers, and hopefully smart enough to reach out to people that I think can help me.
Okay, I'm just going to do two more questions. So, in my experience, many women in pregnancy prefer to inject their thighs for fear of harming their fetus, even when rationale for abdomen site and rotation is explained. Have you seen any research with efficacy of injection sites preferred in pregnancy?
Not specifically in pregnancy, but certainly when we talk about injecting isophane, it's actually recommended to give it in the thigh. That's in our current guideline. If you're using a mixed insulin, it's good to give that at night as well. You get that good isophane effect. So the research says that it reduces the incidence of hypoglycemia, and by injecting into the thigh you're also getting a much slower release. So you're getting a more physiological type of basal insulin release by injecting into the thigh. If you were to choose to use the thigh, then you would need to consider the length of the needle and the lifted skin fold. And probably you'd want to use a shorter needle with a lifted skin fold.
Okay, I think I've got one last question, and it's a verbal question. So I've got Amy Marcos has raised her hand. I don't know if she's still online.
Hello, Amy. I know what you're going to ask me because I've seen your email.
Oh, and she's self-muted herself, so we can't hear you, Amy, if you're trying to talk.
Ah, okay.
No, I'm not sure.
Okay.
Just in case she can. Yep.
I'm assuming the question that Amy has is regarding people who are currently using needles of 8 millimetres or longer, and what do we do about them? That's again one of the questions that needs to be available to be answered in the guideline. At the moment, it says if it isn't broken, don't fix it. If you're getting good efficacy from the medicine and there are no problems with injection sites, why change anything if you don't have to? On the other hand, you may have a professional preference for making a change, and that's fine too. I wouldn't automatically assume that the shortest needle is the best needle. in all scenarios, would be the other response to the question that Amy sent through earlier today.
Okay, I think that wraps up and we are out of time. So just wanted to thank everybody for attending. Also to remind you to follow the prompts and complete the survey at the end, and acknowledge that the webinar is part of a project supported by BD and Novo Nordisk, which we thank very much. So we'll sign off and thank you for attending. You'll receive a recording of this webinar and also your certificate of attendance once you've completed the survey. Thank you and have a great night.
Thanks everybody.